All right, let's jump straight into this explainer. Picture this. A patient suddenly blacks out. The clock is immediately ticking, right? Your mind is probably racing through a massive list of potential causes, everything from completely harmless all the way to immediately life-threatening. The sheer clinical urgency of that moment means you need a rock-solid, structured approach to evaluate that undifferentiated patient.
Here is our roadmap for today. We'll cover the anatomy of a blackout, syncope versus seizure, non-cardiac causes, cardiac causes, a super helpful mnemonic, and finally, clinical investigations.
Starting off with Section 1, the anatomy of a blackout, definition and pathophysiology.
So what exactly is syncope? Well, technically, it's a transient loss of consciousness, usually caused by a sudden drop in blood flow to the brain, global cerebral hypoperfusion. This drop brings a loss of postural tone, which is exactly why the patient hits the deck. But here is the absolute clincher. They recover immediately. If they don't fully lose consciousness and muscle strength, we're just looking at pre-syncope.
Moving to Section 2, syncope versus seizure, comparing the mimics. To tell true syncope apart from a seizure, which is definitely its biggest clinical mimic, you really have to zero in on the recovery phase. It is all about post-loss of consciousness confusion. With a generalized seizure, you get that classic delayed recovery, right? The patient wakes up groggy and disoriented. But with syncope, because brain perfusion bounces right back the second they're lying flat, that post-LOC confusion is completely absent. They wake up fast and they wake up clear.
All right, Section 3, non-cardiac causes, specifically reflex and orthostatic.
Reflex syncope is essentially your autonomic nervous system misfiring in response to a trigger. The classic example is vasovagal syncope. Think severe pain or extreme fear triggering massive vagal stimulation, leading straight to bradycardia and hypotension. But there are also these incredible situational triggers, like post-micturition syncope right after urinating, or post-tussive. This one's fascinating. A really severe cough spikes intrathoracic pressure so much that it chokes off venous return to the heart, literally shutting the lights out. And we can't forget carotid sinus hypersensitivity, where something as simple as moving the neck, shaving, or a neck massage can trigger a blackout.
Then we've got orthostatic syncope, which is driven by a postural drop in blood pressure. The exact diagnostic criteria here require a drop of 20 millimeters of mercury in systolic blood pressure or 10 in diastolic. But timing is everything with this one. You have to catch this drop within 2 to 5 minutes of the patient standing up. You'll typically see this caused by prolonged standing, hypovolemia, or autonomic neuropathy in diabetic patients.
Next up, Section 4, cardiac causes, which carry a high mortality risk. When we talk cardiac syncope, arrhythmias and heart blocks are your most common suspects. The heart rhythm gets so out of whack, beating too slowly, too fast, or too irregularly, that it just can't pump enough blood up to the brain. Take sick sinus syndrome, where you get this wild swing between bradycardia and tachycardia, often with a dangerously long pause, or asystole, right in the middle. And this brings us to a massive red flag, Stokes-Adams syndrome. While reflex syncope usually happens when a person is upright, cardiac causes like Stokes-Adams can hit a patient even when they are lying completely flat on their back. Aortic stenosis, severe myocardial infarction, and atrial myxomas also fall squarely into this critical category.
Section 5, the mnemonic. HFAD heart vessels.
Our source provides this complete differential diagnosis framework wrapped up nicely in the mnemonic HFAD heart vessels. Now, I know it looks like a ton of information to take in all at once, but we're going to break it down logically, piece by piece, so it actually sticks with you when you're on the wards.
Let's kick it off with the HFAD cluster, which catches the major systemic and neuromasqueraders. H is for hypoxia or hypoglycemia. F stands for epilepsy, specifically convulsive syncope that comes with tonic or myoclonic activity. A covers anxiety and psychiatric illnesses, and D is for disorders of the brainstem. A prime example here is vertebro-basilar arterial disease. This is where a reduction in blood supply in the lower brain causes syncope, and it's classically triggered by simply extending the neck backward.
Moving on to the heart portion. This perfectly encapsulates the life-threatening cardiopulmonary conditions. H for heart attack, or MI. E for a massive pulmonary embolism. A for aortic stenosis, where you have a literal mechanical roadblock to cardiac output. R is for rhythm abnormalities, like heart block or AFib. And T is for tachycardia, like SVT. If your patient's blackout is coming from this list, they need immediate, aggressive intervention.
Wrapping up the mnemonic, the vessels section catches the reflex issues and some truly bizarre vascular phenomena. V is vasovagal,
E is for electrolyte imbalances like hyponatremia, and rare ENT issues like vagoglosopharyngeal neuralgia, which gives you sharp pain and occasional syncope. The first S covers situational triggers like coughing or peeing, but also subclavian steal syndrome. This one is wild. Narrowing in the subclavian artery actually reverses blood flow in the vertebral artery, literally stealing perfusion away from the brain. L is low systemic vascular resistance, pointing right back to orthostatic syncope. And the final S is sensitivity of the carotid sinus.
Section 6. Clinical investigations and the diagnostic workup.
So, having built out this massive differential, how do we systematically work it up? It starts with the basics. Check that blood sugar immediately to rule out hypoglycemia. Then, get your baseline cardiac tests in order. Snag an ECG, and maybe consider a treadmill test or a 24-hour Holter monitor to definitively rule out those dangerous hidden arrhythmias. Get an echocardiogram on board for anyone where you suspect structural heart disease. And, of course, if their history sounds more like they were confused when they woke up, rather than having an immediate recovery, you definitely need an EEG to exclude underlying seizure activity.
When you move to specific bedside interventions, you really need to know what positive criteria actually look like. Take the carotid sinus massage. You'd consider this in suspected cases for patients over 40 years old. You are trying to provoke a profound physiological reflex. A positive test here means you induce asystole, a literal pause in the heartbeat for at least 3 seconds, or you observe a massive drop in systolic blood pressure of at least 50 millimeters of mercury. Finally, if their story points to a postural trigger, if they tell you the room goes dark every time they stand up, or if you highly suspect a reflex mechanism, the orthostatic challenge becomes your definitive diagnostic tool. This means physically checking their lying and standing blood pressures, or for more complex cases, referring the patient out for a formal head-up tilt test.
All right, we've walked through the pathophysiology, the red flags, and our complete diagnostic framework. So I want to leave you with this to consider. The very next time the lights go out for a patient and they arrive in your care, how will you use this structural framework to quickly bring clarity to their diagnosis? Keep that mnemonic fresh in your mind, let the clinical history drive your investigations, and stay focused out there. Catch you on the next explainer.